Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 153 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, BHP, a 13-year-old male adolescent is brought by ambulance to your accident and emergency department with a chief complaint of severe left arm pain, erythema, and edema. Bullous blisters cover his arm, which he says began to appear yesterday and have gotten much worse. He also reports that the pain, swelling, and redness have drastically worsened since yesterday. 2 days ago, he went hiking with friends and fell and cut his arm on a rock. So my question to you is, which of the options listed below would be the most appropriate therapy for BHP at this time? Would it be A. Call the surgeon on call now for surgical evaluation and initiate penicillin G plus clindamycin, or B. Administer piperacillin, tazobactam and vancomycin now and admit to the general medical ward, or C. Call the surgeon on call now for surgical evaluation and initiate imipenem, cilastatin plus vancomycin, or would it be D. Administer ceftriaxone IM now and admit to the medical intensive care unit? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Call the surgeon on call now for surgical evaluation and initiate imipenem, cilastatin plus vancomycin. BHP has necrotizing fasciitis, given his clinical presentation. Patients with necrotizing fasciitis should undergo immediate surgical evaluation to excise the infected tissues, making answers D and B incorrect. Patients undergoing empiric treatment for this disease should be initiated on broad-spectrum therapy until culture results return. The combination of penicillin G and clindamycin is the treatment of choice for a documented Streptococcus pyogenes infection. Although this patient could well be infected with this organism, at this point, the treatment is empiric, and this combination is not broad-spectrum enough to cover for other potential pathogens, making answer A incorrect. Therefore, the combination of imipenem, cilastatin and vancomycin is most appropriate at this time, making answer C correct. Please advance to the next slide. And the next question reads, HDL, a 65-year-old male patient presents to your accident and emergency department for a routine checkup. He has a past medical history significant for uncontrolled type 2 diabetes mellitus, hypertension, and dyslipidemia. When examining HDL's left foot, the emergency medicine consultant notes a large ulcer on his heel. The area around the ulcer is warm to the touch, erythematous, and tender on palpation and has a bad odor. The erythematous area around the ulcer is about 0.8 centimeters. He has a history of diabetic foot infections, abbreviated as DFIs, the most recent of which was 13 months ago with MRSA. His pertinent vitals include a body temperature of 37.3 degrees Celsius, a HEAR rate of 76 beats per minute, a blood pressure of 134 systolic 90 diastolic, and a respiratory rate of 20 breaths per minute. He is allergic to sulfonamides, and the last time he received a sulfonamide he had severe rash. So my question to you is, which of the following statements best depicts the perfusion, extent, depth, infection, and sensation, abbreviated as PEDIS, and Infectious Diseases Society of America IDSA grading schemes for this patient? Is it A. PEDIS grade 4, severe infection according to the IDSA, or B. PEDIS grade 3, moderate infection according to the IDSA, or C. PEDIS grade 2, mild infection according to the IDSA, or is it D. PEDIS grade 1, not infected according to the IDSA? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. PEDIS grade 2, mild infection according to the IDSA. This patient's diabetic foot infection, abbreviated as DFI, would be considered PEDIS grade 2 and a mild infection, according to the IDSA. That makes answer C correct and answers A, B, and D incorrect. The patient has a local infection, given that his erythema is warm to the touch, tender, and odorous. The erythema is 0.5 to 2 centimeters. He has no systemic signs or symptoms of infection. This places him at PEDIS 2 and a mild infection, according to the IDSA. Please advance to the next question. And the next question reads, which of the regimens listed below would be the most appropriate for HDL's treatment at this time? Would it be A. admission to the hospital to receive vancomycin, or B. doxycycline for 1 week and re-evaluation with the PCP on day 7, or C. linezolid for 1 week and re-evaluation with the PCP on day 7, or would it be D. cephalexin for 10 days and re-evaluation by the PCP on day 10? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. doxycycline for 1 week and re-evaluation with the PCP on day 7. Because HDL has a mild infection, he can be treated as an outpatient. That makes answer A incorrect. This patient has a history of MRSA, hence, any antimicrobial coverage should include that, making cephalexin answer D incorrect. Linezolid covers gram-positive organisms and MRSA well, however, linezolid should be reserved for more severe infections or infections not responsive to usual therapy, which makes answer C incorrect. Doxycycline provides the necessary coverage for this patient and should thus be used first. That makes answer B correct. Please advance to the next question. And the next question reads, AJJ, a 56-year-old female patient presents to your hospital for severe back pain despite no apparent injury. According to her surgical history, she had arthroscopic repair of a torn knee meniscus 3 months earlier. Her pertinent vitals include a body temperature of 37.1 degrees Celsius, a heart rate of 82 beats per minute, a blood pressure of 130 systolic, 86 diastolic, and a respiratory rate of 20 breaths per minute. Her pertinent lab results are within normal limits, except for a WBC of 12 times 10 power 3 cells per millimeter cubed, an ESR of 92 mm per hour, and a CRP of 18 mg per deciliter. She is admitted for further workup of suspected native vertebral osteomyelitis, abbreviated as NVO. So my question to you is, which of the following would be the most appropriate next step in this AJJ's therapy? Would it be A. Obtain an image-guided spinal biopsy, and start empiric antimicrobial therapy with ciprofloxacin plus vancomycin, or B. Obtain an image-guided spinal biopsy, but do not start antimicrobial therapy at this time, or C. Obtain blood cultures and an MRI of the spine, and initiate empiric antimicrobial therapy with meropenem and vancomycin, or would it be D. Obtain blood cultures and perform magnetic resonance imaging MRI of the spine, do not start antimicrobial therapy at this time? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Obtain blood cultures and perform magnetic resonance imaging MRI of the spine. Do not start antimicrobial therapy at this time. This patient's infection is highly suggestive of NVO because of her clinical symptoms, recent history of the knee surgery, and elevated ESR and CRP. However, she is hemodynamically stable. In this scenario, it is recommended to obtain blood cultures and MRI results and not to administer antimicrobial therapy until a microbiologic diagnosis can be established. That makes answer D correct, and answer C incorrect. An image-guided biopsy would not be needed unless the blood cultures were not positive, which makes answers B and A incorrect. Please advance to the next slide. And the next question reads, JTD, a 33-year-old female brings her 3-year-old daughter, KSD, to her pediatrician for evaluation of 2 small, yellowish lesions on her upper lip. JTD informs the pediatrician that yesterday, they looked like small pustules that burst today, leaving the yellowish fluid. This has never happened in KSD, and her mother is concerned that it is serious. KSD is otherwise healthy, with normal vital signs in the pediatrician's office. So my question to you is, what is the most likely diagnosis for KSD? Is it A. cellulitis, or B. ectyma, or C. non-bullous impetigo, or is it D. furuncles? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. non-bullous impetigo. This patient probably has non-bullous impetigo, which is most common in children and is characterized by small pustules that burst, leaving behind a yellowish crust, which makes answer C correct. Furuncles would not generally appear on the upper lip, though they could. Also, they would probably be larger than what the mother described, and the yellowish crusting does not usually occur with furuncles. That makes answer D incorrect. Ectyma is a deeper infection. Though lesions rupture, they usually leave edematous, erythematous tissue around the site, which was not what was described, which makes answer B incorrect. Cellulitis does not have a focal area the way it was described in this case. That makes answer A incorrect. Please proceed to the next slide. And the next question reads, which of the following would be the most appropriate regimen for JTD's daughter at this time? Would it be A. penicillin for 10 days, or B. doxycycline for 1 week, or C. cephalexin for 10 days, or would it be D. mepiosin applied to the lesions twice daily for 5 days? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. mepiosin applied to the lesions twice daily for 5 days. Many impetigo cases can be treated with topical therapy. Oral therapy is recommended when a patient has several lesions. This patient has only 2 lesions. Or in outbreaks affecting several people. The lesions on this patient are also described as very small, so topical therapy could be used. That makes answer D correct. If oral therapy were used, the empiric treatment of choice would be dicloxacillin or cephalexin for 7 days. Answer C is therefore incorrect because of the length of therapy. Doxycycline would only be used if MRSA were suspected, and MRSA is a rare cause of impetigo. In addition, this patient is 3 years of age, and tetracyclines should not be used in children younger than 8 years, making answer B incorrect. Answer A is incorrect because penicillin should only be used when the infection is proven to be caused by Streptococcus species, and in this case, we do not have the culture and susceptibility results. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 154.